Dear viewers, in previous video I discussed male sex hormones, and today I'll be exploring the sources of hyperandrogenism in pregnant women. If this topic interests you, stay tuned. I'm Dr. Lena Berezovsky and I'm delighted to welcome you to my channel. Don't forget to like, comment and subscribe to keep up with future content. During pregnancy, there is a natural increase in male sex hormones due to high levels of progesterone and estrogen. This physiological change means that generally we don't monitor androgen levels in pregnant women. The most common cause of elevated androgen levels in pregnancy is luteomas, benign tumor-like ovarian formations that develop with the rapid growth of lutein cells. These pseudotumors appear only during pregnancy and typically resolve on the ovum after childbirth. Luteomas are relatively common but usually produce minimal amounts of androgens, so they rarely lead to signs of realization such as excessive hair growth and other symptoms in either the mother or the child. Luteomas can range in size from 1 to 25 centimeters, averaging 6-10 centimeters, and appear in both ovaries in about half of cases. Ultrasound often reveals hemorrhagic areas within these tumors, and pregnant women may show elevated levels of testosterone, dihydrotestosterone, and androstenedione, along with increased 17-ketosteroids in the urine. These tumors are typically diagnosed in the second half of pregnancy. Approximately 30-35% of women with luteomas experience hirsutism, but realization in female fetuses is rare. Luteomas generally require no treatment and monitoring is sufficient. However, in rare cases, surgical removal may be considered. Another source of elevated androgen levels in pregnancy is teca-lutein cyst, often associated with multiple pregnancies, trophoblastic disease such as a molar pregnancy or chorion carcinoma, and diabetes. Unlike luteomas, these are fluid-filled sacs rather than tumors. Up to 30% of women with teca-lutein cyst may show mild signs of realization. Also, fetal testosterone and androgen levels usually remain normal. Worldwide, only a few cases have been documented where daughters of mothers with this cyst showed signs of realization. For this reason, it is believed that there is no direct link between teca-lutein cyst and fetal realization, despite elevated androgen levels in the mother's blood. The third source is increased androgens in pregnancy is the use of synthetic hormones, progestins, androgens, and dihydrotilbestrol. Until recently, many women used synthetic progesterone to prevent miscarriages due to luteal phase insufficiency. There are documented cases of realization in daughters born to women who took progestins before conceptions and during early pregnancy. Erroneous androgen administration in early pregnancy can also lead to fetal virilization in female fetuses. Also, these cases are very rare, and healthy baby girls are generally born despite such treatments. In cases of polycystic ovary syndrome (PCOS), some women may exhibit mild signs of realization. Only a few, however, experience a slight increase in male hormones levels during pregnancy, which doesn't pose a risk to female fetuses. Simply put, fetal realization does not occur in pregnancy with polycystic ovary syndrome. True hyperandrogenism in pregnancy is exceptionally rare. So we've covered the causes of hyperandrogenism in pregnant women. This brings up an important question. Who should be treated for hyperandrogenism if fetal realization is less common than often perceived? And when should medications like prednisolone or its analogs be used to prevent realization in female fetuses? Errors in diagnosis often arise when laboratories overlook age-related variations while assessing androgen levels or other substances. Lab results are typically standardized for non-pregnant women age 15-80, so testosterone levels vary greatly across the span. For pregnant women, many lab values lack established normal ranges. Another common mistake by healthcare providers is prescribing medication based on a single lab results, treating the lab value rather than the actual condition. In obstetrics, glucocorticoids are primarily used to treat autoimmune diseases in women, including asthma, arthritis, ulcerative colitis, psoriasis, and lupus. Their effect on the fetus are well documented, but the recommendation remains clear. If potentially harmful medications can be avoided, it's best to discontinue or limit their use. Research suggests that glucocorticoids such as prednisolone and dexamethasone may lead to developmental issues including cleft palate, cleft lip, and eye anomalies. Prolonged glucocorticoid use is suspected to increase the risk of preterm birth and low birth weight, so opinions among healthcare professionals remain divided. Congenital adrenal hyperplasia is likely the only hyperandrogenic condition requiring steroids medication to prevent virilization in female fetuses. Confirming a congenital adrenal hyperplasia diagnosis usually takes several months and involves genotyping to determine the type of hyperplasia, as not all forms necessitate steroids treatment. Women with adrenal tumors may also require glucocorticoids. In such cases, dexamethasone or prednisolone is often prescribed starting at 7-8 weeks of pregnancy, continuing until delivery. This steroid suppresses the production of adrenocorticotropic hormone in the adrenal cortex, thereby reducing the conversion of the excess of adrenocorticotropic hormone into male sex hormones. However, if ultrasound or other tests confirm a male fetus, glucocorticoid treatment is usually stopped. For all other forms of hyperandrogenism, glucocorticoids are not recommended. Remember, it is essential to treat the condition, not merely the lab result. We'll continue exploring pregnancy-related topics, so stay tuned by subscribing to my channel to catch future videos. Wishing you all the best. See you soon.